We'll start the topic from the Williams 26th edition. The topic is physiology of labor. What is labor? Labor is characterized by forceful and painful uterine contraction. That affect cervical dilatation and cause the fetus to descend through the birth canal. Okay. There is three theory to the physiological process that regulate the maturation and the onset of labor. The three theories describe the labor initiation. The first theory, the functional loss of pregnancy maintenance factors. Second is focus on the synthesis of factors that induce maturation. Third theory suggests mature fetus is the source of initial signal for maturation commencement. The various research support a model that draw from all the three themes. Thus, labor onset represents the accumulation of series of biochemical changes in the uterus and the cervix. First, in the maternal fetal compartment, the uterus and cervical changes. The myometrial layer of the uterus is composed of a bundle of smooth muscle cells surrounded by connective tissue. What is the difference from the skeletal and cardiac muscle? The smooth muscle cells is not terminally differentiated. That is present in the uterus, therefore is readily adaptable to environmental changes. If there is many stimuli that such as like mechanical stretch, inflammation, or endocrine or paracrine signal, that will modulate the transition of this smooth muscle cell into phenotype that to provide the growth and proliferation and secretion and contractility of the uterine smooth muscle cell. Additionally, several smooth muscle quality confer the advantage of uterine contraction efficiently and deliver the fetus. What are the additional benefit of the smooth muscle in the uterus? The first, the degree of smooth muscle cell shortening and contraction compared to the striated muscle. Second, the force that can be exerted in this smooth muscle cell is in multiple direction compared to in the skeletal muscle, where it is aligned along with the axis of the muscle fiber. Third, the thick and thin filament of smooth muscles are found in long and random bundle throughout the cells. This flexiform arrangement augment the shortening and force generating capacity. Last, the greater the multi-directional force in the smooth muscle that will generate in the uterine fundus compare with that the lower segment. The more force is generated in the uterine fundus compared to the lower uterine segment, helps to optimize the expulsive force vectors towards downward and deliver the fetus. Then the end lining the thick muscular uterine wall, the endometrium is transferred by pregnancy hormone that is called decidua. What is decidua? Due to the effect of the pregnancy hormone, the endometrium transfer into decidua. Okay. The compass of stromal cell, maternal immune cells, the decidua serves as the immunoregulatory function, suppress the inflammatory signal during the gestation. However, the end of pregnancy, decidua transition to induce inflammatory signal and withdraw the active. At the end of pregnancy, what happens? The decidua transition to induce an inflammatory signals and withdraw the active immunosuppression that contribute to the maturation initiation. During pregnancy, the cervix has multiple function. What are the function of the pregnancy cervix? First thing is the maintaining the epithelial barrier to protect the reproductive tract from the infection. Second, the sustaining cervical competence to prevent the preterm labor, cervical incompetency despite greater gravitational force as fetus grows. And third one is the extracellular matrix that allow progressively greater tissue compliance. In non-pregnant, the cervix is closed, firm. It consists similar to the nasal cartilage. By the end of the pregnancy, the cervix is easily distensible and its consistency is similar to the leaf of the oral cavity. The cervix has a high ratio of fibroblasts to smooth muscle cells. Another thing, the smooth muscle cells make up to 50% of stromal cell at the internal loss, but this is the difference in the percentage of smooth muscle cell in the internal loss and the external loss. At internal loss, it is 50% stromal cell. But only 10% at the external loss. Then placenta. What is the function of the placenta? Placenta provides the exchange of nutrient and waste between the mother and fetus. The placenta is a key source of steroid hormones and growth factor and other mediator that will maintain the pregnancy and potentially at the transition to the maturation. The fetal membrane, that is amnion and chorion and adjacent decidua, serve as a physiologic, immunologic and metabolic shield to protect against ultimately maturation initiation. What is the function? Amnion is a fetal membrane that is completely avascular tissue. It is highly resistant. Because of amnion is a thick membrane, it is resistant to penetration by leukocyte and microorganism. And this it also consists it acts as the amnion act as selective filter barrier to prevent fetus particulate bound lung and skin secretion from reaching the maternal compartment to maternal compartment into the maternal compartment. In this manner, what happened? The amniotic fluid consists prematurely accelerated decidual and myometrial activation, or could promote adverse event such as amniotic fluid embolism. That will prevent the amniotic fluid embolism because of the thick membrane that is a prevent as a barrier that will prevent the passes of secretion from the secretion like fetal particulate bound like long hair, skin, lanugo hair, all this and skin secretion from the fetal to maternal compartment to prevent amniotic fluid embolism. Okay. Amnion, this is the amniotic fluid. This is amniotic fluid. This is amnionic epithelium. This is the amnion chorion mesenchyma. Okay, this is decidual cytoplast. This figure, what is this signify? The amnion, what happened in the amnion synthesizes the prostaglandin, and in late in pregnancy this synthesis is augmented by increased phospholipase A2 and prostaglandin H synthase, that is type 2 PGHS2 activity. The transport of prostaglandin from the amnion to the maternal tissue is limited by the expression of the inactivating enzyme, that is the prostaglandin dehydrogenase. What happened? This amnion synthesizes the prostaglandin, but this prostaglandin is unable to cross the prostaglandin is metabolized by prostaglandin dehydrogenase. So the prostaglandin cannot reach to the maternal compartment, and that prevent the premature activation of the contraction that led to preterm labor. During labor, this what happened? During labor, this PGDH activity, that dehydrogenase activity, that is limit the prostaglandin E2 metabolism, that will metabolize the prostaglandin all the prostaglandin before labor, but in during labor the prostaglandin dehydrogenase activity is decline, and that will lead to amnion derived prostaglandin can influence the membrane rupture and uterine contractility. The role of decidual activation in parturition is unclear, but they may suspect that local progesterone metabolism, higher prostaglandin receptor concentrations, thus enhancing the uterine prostaglandin action and cytokine production in the residua. The chorion is primarily, what is the function of chorion? Chorion primarily protective tissue layer that provide immunological acceptance. It is also enriched with enzyme that inactivate uterotonin, which are agents stimulate contraction and inactivate enzyme like prostaglandin dehydrogenase oxygen. These are the inactivating enzyme that is present in the chorion that will prevent the prostaglandin that will metabolize the prostaglandin like prostaglandin dehydrogenase, metabolize the oxytocin, oxytocinase and encapsulinase that metabolize the encapsulin. So that all these things that protect early initiation of labor before term. Then what is the function of sex steroid hormone? In many cases sex steroid is clear. Estrogen promote and progesterone inhibit leading to the patch. This is other species, but the removal of progesterone, that is progesterone, will directly progression patch. These things are in the not in human species. In addition to providing progesterone to some species, will delay parturition, have declared myometrial activity. But in human, these are all these things are in the other species. But in human, however, both estrogen and progesterone are component of a broader molecular system that maintain uterine coherence. Another thing is increase progesterone to estrogen ratio in the maintenance of pregnancy. If it is decline in this ratio, that leads to parturition initiation. Suppose you are in administration the progesterone antagonist like mifepristone RU486 onafpristone will promote some all key feature of parturition, cervical ripening, greater cervical distensibility, augment uterine sensitivity to uterotonic. Both progesterone and estrogen bind to nuclear receptor, progesterone receptor A and B and estrogen receptor A and B. What is the role of prostaglandin? Prostaglandin is a lipid molecule that is varied with hormone-like action. In parturition, they play a prominent role in myometrial contractility, relaxation, inflammation. There is prostaglandin interact with the G protein coupled receptor, which express in the myometrium and the cervix. The major synthetic pathway is synthesis from the arachidonic acid by the help of the enzyme phospholipase A2 or C. There is two. This is the pathway. Arachidonic acid in the phospholipid store that is converted by the phospholipase A2 or phospholipase enzyme converted to arachidonic acid. This arachidonic acid, with the help of COX-1 and COX-2, that is PGHS1 and PGHS2, it is converted into PGH2, and then PG isomerase is converted to PGE2, PGF2 alpha and PGI2, and these things are metabolize, if she is not in labor, not in term, these three things, the prostaglandin E2, F2 alpha and I2, that will be metabolized by prostaglandin dehydrogenase, that is secreted by the chorion and amnion, that is inactivate the prostaglandin metabolite and prevent the preterm labor through the prostaglandin isomerase is converted to the active prostaglandin. Okay, the expression of this PGDH during pregnancy in the uterus and cervix provide an important ability to rapidly inactivate the prostaglandin. Thus, the myometal response to prostaglandin stem from a balance between prostaglandin synthesis versus metabolism. Prostaglandin contribute to the relaxation stage of pregnancy. Myometal control after vagination. In addition to the myometal, amnion synthesizes several bioactive peptides like cause myometal relaxation, contraction. Amnion is the likely major source of amniotic fluid prostaglandin. Their role in the activate cascade. Phase 1. There is uterine quiescence, cervical softening. What is phase 1? There is 4 phase. 4 phase of initiation of parturition. These 4 phases are initial parturition phases, not the stages of labor. Stages of labor is 3 stages, that is different. And phase of parturition is 4. That is phase 1 is quiescence phase or prelude to parturition, before parturition. Phase 2 activation or preparation for labor. Phase 3 stimulation or process of labor. Phase 4 is involution after labor, after delivery, parturient recovery. This is the what happened in phase 1, that is phase of quiescence. In this stage, quiescence, uterus in quiescence stage before the parturition, contractility on responsiveness, cervical softening, only this thing, cervical softening in the phase 1. Then phase 2, that is the activation phase, that is the you have to prepare the preparation for labor. Now how will you prepare uterine preparedness for labor, like cervical ripening. Then phase 3, process of labor, already it is started, means uterine contraction is started, cervical dilatation started, fetal and placental expulsion. Then all the 3 stages of labor in phase 3, stimulation, process of labor, all these 3 are in this phase. Okay, phase 4, involution, that is parturient recovery, prelude, preparation, process and parturient. Prelude, preparation, process and parturient, uterine involution, cervical repair, breastfeeding, fertility restored. Okay, these all 4 phases of parturition. In phase 1, what is the phase 1? Uterine quiescence and cervical softening. Uterine quiescence parturition can be arbitrarily divided into 4 overlapping phases that correspond to major physiological transition of the myometal cervix during pregnancy. First phase, prelude phase, then is preparation phase, the advanced process itself, and the recovery phase. Importantly, the phase of parturition should not be confused with the clinical stage of labor. The first, second, and third stage make up phase 3 of parturition. All phase 3, the process of labor started, initiation, stimulation of labor, that is all in phase 3. All the 3 stages in phase 3 process, phase 3 of parturition. Beginning of the event before implantation, effective period of myometal quiescence impulse. The phase 1 normally what is the phase 1? Phase 1 consists of 95% of total duration of pregnancy, and it is characterized by uterine smooth muscle tranquility with maintenance of cervical structural integrity by the neural, endocrine, paracrine and autocrine implemented according to all these systems and make the uterine on responsiveness and quiescence stage. In phase 1, this the major site of the key factor that regulate the process of each phase of the parturition. That is in phase 1, that what are the things that will protect, maintain the uterine quiescence, that is prostacyclin, nitric oxide, HCG, and corticotropin releasing hormone, caspase 3, period of immunocompetence, progesterone and prostaglandin dehydrogenase that will metabolize all the prostaglandin I2, F2, alpha, E2. Then phase 2, that is the preparation before labor. What are the things to prepare? What are the things it will prepare? First, because of uterine stage, that will stimulate the uterine stage, that will gap junction receptor, fetal signal like surfactant protein A, fetal activating factor, corticotropin releasing hormone secreted from the hypothalamus of fetus brain. Then fetal membrane senescence, prostaglandin, cortisols, progesterone, non-classical erythritol, estrogen and relaxin, and hyaluron in the phase 2. All the preparation phase. Then phase 3, that is the process or stimulation. Already it has started. Then what are the things will stimulate the labor? Prostaglandin, oxytocin, corticotropin releasing hormone, inflammatory cell activation, estrogen, relaxin. In the last phase, that is the phase of recovery phase, that is the recovery phase or peripheral phase, the oxytocin, inflammatory cell activation. Okay, what happened in during phase 1? The uterus must initiate extensive changes in its size. What happened in phase 1? Phase 1 is the prelude phase or just to prelude phase or quiescence phase. In this stage, in this phase 1, initiate extension in size and vascularity. To what happened in the phase 1, the fetus has to grow, so the uterus has to change in its size and increase in the vasculature to accommodate the fetus growth. Okay, concurrently the myometrial cell undergo phenotype modification to a non-contractile state, and a uterine muscle remain unresponsive to natural stimuli. Although this okay, don't normally cause cervical dilation. They refer to some this contraction, although this unless continue until near the end of pregnancy. Some low intensity myometrial contraction are felt during this quiescence phase, that is called as Braxton Hicks contraction or false labor, that don't normally cause a cervical dilatation. They are common toward the end of the pregnancy, especially in multiparous. The questions phase 1 likely stems from the what are the factor action of estrogen, progesterone by intracellular receptor, myometrial cell plasma membrane receptor mediated increased cyclic adenyl phosphate, and generation of CGMP and other system including the myometrial cell ion channel. First one is a myometrial relaxation and contraction. How it will maintain the relaxation and contraction? What are the factors? The balance between the myometrial relaxation controlled by steroid and peptide hormone transcriptor regulation key gene. Quiescence is achieved by diminution of the intracellular crosstalk of reduced intracellular calcium, ion channel regulation of cell membrane potential, activation of the stress unfolded protein, uterotonic degradation. Okay. In contrast, the contraction, these are the things that maintain the quiescence, that is the maintain the relaxation of the uterus. First one is the diminished intracellular crosstalk and reduced intracellular calcium, ion channel regulation of cell membrane potential, activation of the stress unfolded protein response by the uterine endoplasmic reticulum, uterotonic degradation. These are the things that maintain the quiescence, that is maintain the uterine relaxation. What are the factors that maintain the uterine contractility? Enhance the interaction between the actin and myosin protein. First one, the heightened excitability of individual myometrial cell, promote intracellular crosstalk and allow the synchronous contraction to develop by the help of calcium. Actin myosin interaction. Okay, you understand this thing? Okay, here the corticotropin releasing hormone or beta sympathomimetic like or prostaglandin E2, that is through the G protein coupled receptor. What happens? The ATP is converted to the cyclic AMP. The cyclic AMP activate the protein kinase A, and the protein kinase A, this is the smooth muscle that is in the relaxation phase. What are the mechanism? The corticotropin releasing hormone, beta sympathomimetic, prostaglandin E2 bind to the G protein coupled receptor, and that will convert the ATP to cyclic AMP. Cyclic AMP is converted activate the protein kinase A. Now the protein kinase A, it will be activate the phosphatase enzyme. Then the phosphatase enzyme is lead to a dephosphorylation of the phosphomyosin light chain kinase 20, that will lead to dephosphorylation. Now it cannot bind to the myosin. Now the myosin head is inactivate, and it also make the actin filament. If it is in the globular state, like small globular state, it will not bind to the myosin complex, not it lead to the relaxation. Same thing, opposite thing, that is the oxytocin, thrombin, prostaglandin F2 alpha, that lead to contraction through the G alpha protein coupled receptor. The phosphoinositol now called diacylglycerin inositol phosphate 3, and that will activate the that will stimulate the release of calcium from the sarcoplasmic reticulum, and from the increase the intracellular calcium from the outside cell membrane. In the calcium now increase, the calcium may combine with the calcium calmodulin complex, and that will activate the myosin light chain kinase, and that will phosphorylate the myosin LC20 chain, and myosin LC20 become phosphorylate too. Now it is the myosin chain. Myosin chain is active. Now actin also in the filamentous form, that will bind to the actin myosin complex, that lead to contraction. Okay. The logical uterine relaxation auditory prompted condition of lower contraction, calcium 2. In contrast is in that promote contraction on calcium. PGF2 alpha, oxytocin bind the respective receptor during labor to open ligand-gated activate calcium channel. Activation of this receptor release calcium from the sarcoplasmic reticulum. Additionally, greater localization non-selective calcium channel entry. Okay. And the second thing, the regulation of membrane potential. Myocyte maintain the relatively higher inter-electronegativity, maintains the hyperpolarized membrane potential attend the smooth muscle relaxation. If you maintain the membrane in the hyperpolarization, that is the interior electronegativity, then it will be prevent the maintain the uterus smooth muscle cell in relaxation phase. Okay, numerous ion-gated channels like sodium channel, calcium channel, potassium channel, large conductors voltage and calcium activated potassium channel. This BKCA channel is abundantly expressed in the myometrium. That is, they play a dual promoting and opposing role in the maintain the balance between the uterine quiescence and contractility. If you how is this maintain the electronegativity? If you open the BKCA channel, that will allow the potassium to leave the cell to maintain interior electronegativity. If you the interior of the cell maintain electronegativity, that will preventing the voltage gated calcium channel influx and contraction. So opening of BKCA channel allow the potassium to leave the cell to maintain the interior electronegativity. That will preventing the voltage gated calcium influx and contraction. Same thing, if you inhibit the BKCA channel, that will augment the myometrial contraction by opposite action. Okay, these are the myometrial gap junction. This between the communication establishment myometrial gap junction, electrical through this gap junction, that is electrical or ionic coupling current as well as metabolic coupling pass through the other cells, the surrounding cell. The connection family of protein from cell type specific gap junction. Connection 43 is expressed in the myometrium and concentration rise near labor onset. 6 connections subunit form a connection. 2 adjacent connection establish a conduit between the communicating cell. This permit exchange of small molecules that can be nutrient, waste, metabolite, second messenger or iron. What happened? Progesterone promote uterine quiescence in part by lowering the expression of the progesterone maintain the uterine quiescence by lowering the expression of the contraction associated protein like CAPS, maintain expression anticontractile agent caspase 3. The progesterone maintain the quiescence by lowering expression of CAPS and caspase 3. CAP include the lower expression contractile associated protein. What are the contractile associated protein? That is the receptor. One is the contractile associated proteins are the receptor. What are the receptor? One is oxytocin receptor, prostaglandin F receptor, and connexin 43. Okay. Also, at the end of pregnancy, increased stretch or metabolism progesterone by the enzyme 20. What happened? Increased stretch or metabolism progesterone 20 hydroxy steroid adenine, loss of progesterone mediated repression of SCAP gene, greater estrogen dominance, raise the contractile associated protein levels that will lead to contraction. Integration of diverse global culminate the release of inhibition of connection 43 oxytocin level promote greater uterine contractility. GPCR already you have read. Economist. The CRH, corticotropin releasing hormone synthesized in the placenta and hypothalamus. CRH plasma level rise dramatically in the final 6 to 8 weeks of normal pregnancy and implicated in mechanism under the timing of the human parturition. Okay, CRH appeared on mammal questions during most of the pregnancy, but then add contraction with parturition onset. This opposing action achieved by differential action of CRH by receptor 1. A non-laboring myometrium at term interaction CRH activate the CMP signal path. This results in inhibition of the inositol phosphate and stabilization of calcium level. However, in term laboring myometer, calcium concentration augmented by CRH activation and of G protein stimulation greater contractility. What is decidua? To answer uterine question, the synthesis of decidua prostaglandin, in particular PGF2 alpha, is markedly suppressed in decidua. The suppression persists throughout the most pregnancy. Suppression of withdrawal is a precursor of parturition. Then cervical softening. Initial stage of cervical remodeling, term softening, beginning phase of phase 1 parturition. Initial stage of cervical remodeling is the cervical softening. Okay, beginning in phase 1 of parturition. Softening is phase 1 of parturition, characterized by greater tissue complex, lower uterine segment 4 to 6, and fast palpable softening of the lower uterine 4 to 6 weeks of the gestational age. This was first described by the Hager, so it is called as Hager sign, softening of the cervix. Cervical connective tissue. Then this is the phase 1. This second phase is the phase 2 is the preparation of labor. Preparation for labor. To prepare the labor, myometrial tranquility, phase 1 of parturition must be suspended. Now the phase 1, that question stage all has to be suspended to come into the phase 2. That is this is called so-called uterine awakening or activation in the phase 2 of parturition is a progression of uterine changes during the last few weeks of pregnancy. Shifting of the event associated with the phase 2 can cause either preterm or delayed labor. If it is done earlier, then it is preterm or delayed labor. What are the key factor? That is progesterone withdrawal. The key factor in uterine activation, already you have studied. The classical progesterone withdrawal from decreased secretion doesn't occur in human patches. However, mechanism of progesterone inactivation, but this is classical thing has not done in human species. However, the mechanism for progesterone inactivation, whereby the myometric cervix become refractory to progesterone inhibitor action, is supported study using progesterone receptor antagonist. The driver mechanism is one is the functional progesterone withdrawal and antagonist is achieved in active area research. The myometrial changes, what happened in phase 2, the changes myometrial has to prepare for the labor contraction, and the changes result from the shift in the expression the protein that control uterine questions to express in CAPS protein like oxytocin receptor, prostaglandin F2 receptor. This CAPS increase on uterine response to uterotonic. Another critical change in the phase 2 is the formation of the lower remember the lower uterine segment is formed in the phase 2 of the prepaturation, that is, it will form the isthmus. With this development, the petal head has to be descend to even through the pelvic inlet. This is called as lightening. The abdomen commonly undergoes shape change, sometimes described as the baby draft. Okay. Then oxytocin receptor has to be increased during the cervical ripening. Cervical modification during phase 2, principally in the connective tissue term cervical ripening. Inflammatory phase, induction, into cervical epithelium.